MTAC. Scott, do you have any announcements or anything before I introduce Dr. Woolworth?
Our biggest thing is, as always, our upcoming trauma symposium on May 12th and 13th. I can put the details in the chat box.
Great. All right. Well, then, if that's all of our announcements, I'm really pleased to introduce our speaker this month. Dr. Melissa Woolworth is well known to many of us here at CMC Maine. She comes to us after bouncing coast to coast, I guess, for a few years, been here since about 2015, after doing her training in the DC area and then being in practice out in Oregon. So like many of us know, when you become really good at disasters, it can somehow define your practice and then it becomes your specialty. So we are thankful for our multidisciplinary relationship with the OBGYN team and specifically with Dr. Woolworth. So we appreciate you joining us. Look forward to hearing your comments on how we all overlap and how we can take care of our patients better by doing it together. So thanks for being with us.
Thank you so much for that introduction, and I really appreciate the invite to spend lunch with you guys today. Yeah, I think you kind of hit it. I started my practice in a rural setting, taking care of a lot of really sick patients without great resources, and from that point on, I really became very interested in trauma and kind of managing more high-risk surgical problems. And so since I've been here, I've been managing our Accreta team, and we've folded that into a kind of complex obstetric delivery planning clinic. So this first picture here is us doing a pretty complicated placenta Accreta case. And so I've just kind of naturally been drawn to these more higher acuity, higher risk cases. And, you know, over the course of working here and getting to know the trauma folks here, I've kind of expanded our Accreta care program to include a really robust multidisciplinary team. And so we are working gynecology and trauma pretty hand in hand, managing these patients and using Reboa and Cobra catheters to mitigate surgical blood loss. So, you know, I would love to talk about that in a separate forum, but you know, trauma and pregnancy is an area that I have another kind of special interest in, and would love to share some pearls of managing these patients. So we're going to do just a quick obstetric physiologic overview, just to remind ourselves of what is different about pregnant patients. And then, you know, obviously I'm not a trauma expert, but I'd like to talk about the maternal and fetal implications of trauma and kind of things that from our standpoint we would like to think about in those initial evaluations. My talk's going to focus mostly on common injuries, traumatic injuries. I'm specifically excluding obstetric critical care, which is a complete another talk, or talks plural. And then kind of in the background, I'd like us all to keep in mind the ethics of caring for two patients, one being the fetus and the other being the mom. And you know, I think another big topic in obstetric care right now are healthcare inequalities and disparities. And so I think trauma is no different. There's certainly healthcare disparities here too, and those are important to keep in mind. Again, that's a whole another series of talks, but I do want to just bring our attention to that as an underlying theme. And then I'm really interested and excited about any opportunity that we have for collaboration. And so you'll see a lot of that throughout my talk. So in terms of prevalence, traumatic injury affects 6 to 8% of all pregnancies. If you look at those patients who are admitted for traumatic injury, about 38% are delivered during hospitalization. And so, you know, whether or not that's an immediate delivery or some, you know, time later, whether that's hours or days, that is a big concern. In terms of mortality, this is the leading cause of non-obstetric maternal death. And then fetal death can be either directly related to maternal instability or direct fetal injury. And these are commonly associated with maternal hemorrhage or premature delivery, whether that is on purpose or required. Many of those are involving placental injuries. About 70% of all traumas are going to be motor vehicle accidents in this population, followed by intimate partner violence. And again, we do see that violence and homicide are leading in some areas of the United States and disproportionately affect Black patients more so than white patients. Less commonly, we can have traumatic falls, homicide, suicide, penetrating traumas, toxic exposure, or burns. So we're going to kind of go through a brief physiologic review of pregnancy. Virtually all organ systems are affected by pregnancy, and these are due to hormonal changes or mechanical changes, just how the gravid uterus affects those surrounding organ systems. Some of those changes are advantageous, while others are disadvantageous, and we'll kind of talk about that. Cardiovascularly, cardiac output is significantly increased during pregnancy. We see changes as early as 8 weeks of pregnancy where the cardiac output is increased by about 20%, and this steadily rises if you look at the graph on the bottom right until about 30 to 32 weeks where it plateaus at about 50% above baseline. And the result of an increased cardiac output is that these patients have greater blood volume, so they have an increased preload. There's a decreased afterload because they have a decreased systemic vascular resistance, which is largely from the progesterone effect in the system. And then we see a physiologic increase in baseline heart rate that's about 15 to 20 beats per minute above baseline. The gravid uterus can cause compression of the IVC, so if patients are lying flat, they can reduce their cardiac output by about 25 to 30%. And if you see in this image, if they have this left lateral decubitus bump or kind of a bump that goes right almost at the small of the back and the upper buttock, usually about 15% of a bump, that can just relieve that pressure on the IVC and the aorta and improve their vascular system. Cardiovascularly, just a couple more comments. A flow murmur is quite normal in pregnancy, and due to all this increased blood volume, we do see a little bit of cardiac remodeling, left-sided hypertrophy, and even some mild valvular regurgitation. And there's also some normal EKG changes associated with that as well. In terms of the pulmonary system, again, progesterone is the main kind of culprit in these hormonal changes, stimulating the respiratory drive, increasing tidal volume, which leads to hyperventilation and a chronic respiratory alkalosis. You can see some of the parameters to the right of a normal arterial blood gas in pregnant patients. We do see about a 20% decrease in functional residual capacity. That's due to a mechanical change just with the gravid uterus moving the diaphragm cephalad. And again, that starts around 20 weeks or second to third trimester. And oxygen consumption increases by about 20%. This is particularly, in my clinic, I focus a lot on morbidly obese pregnant patients and planning for safe delivery, and this is particularly important for that patient population who has a baseline sleep apnea or other pulmonary related diseases, as we can have pretty significantly impacted patients if their baseline is so affected just by pregnancy. In terms of their hematologic changes, plasma volume increases by about 50%, and the total red cell mass increases by only 20 to 30%, which leads to a physiologic hemodilution and anemia of pregnancy. We don't consider pregnant patients to be anemic until they have a hemoglobin that drops below 11 in the first and third trimesters or below 10.5 in the second. Pregnant patients have a mild leukocytosis, and we see normal white counts of 10, 12, 14, even 16, which can be normal. Platelet count is a little bit lower than normal, but is generally still within the reference range. And then pregnancy is also a procoagulant state, so we see changes in their coagulation cascade Additionally, mechanical changes from the gravid uterus causing venous stasis in the lower extremities and pelvic vessels that can increase patients' risk of blood clot. A normal fibrinogen in these patients is usually above 400, although a fibrinogen of 200 to 300 is generally required for normal coagulation. And if our patients drop below 100, that is pretty indicative of DIC or some coagulopathy. In terms of gastrointestinal changes, there's a progesterone-mediated relaxation of the lower esophageal sphincter, which makes them higher risk for gastric aspiration, particularly important for patients who are going to have or require intubation, who may be down in the field. They have a high risk of aspiration, so our differential should be high for that. In terms of the kidneys, there's, again, an increased plasma volume, which increases their GFR, and we see a physiologic decrease in creatinine. So normally our patients have a baseline creatinine of 0.4 to 0.5. It's totally normal. The uterus goes through its own changes. Again, because this is a pelvic organ, less than 12 weeks, it's generally protected by the pelvic bone. And so if a patient is in their first trimester, it's not common to see injuries directly to the uterus during this phase of pregnancy. But after 12 weeks, the uterus enlarges, and that is then susceptible to injury, as it's usually the most presenting part in the patient's abdomen. What this does is then it displaces the bowel both cephalad and laterally, and so that changes our perspective on penetrating injuries, because we might have a bowel injury if they have a penetrating injury above the level of their fundus. Probably the most exciting part for me in terms of what I do with my Accreta clinic is this increased vascular supply that we see with a gravid uterus. The uterine blood flow is about 600 milliliters a minute in the third trimester, and these vessels are not auto-regulated. So it's a ton of their cardiac output is going towards the uterus. And a significant decrease in the maternal blood pressure can cause compromise of fetal perfusion. And so it's really a lot of blood flow, and any of these blunt trauma, penetrating trauma that involves the uterus can really cause a pretty rapid exsanguination or internal hemorrhage. Okay, those are the basics on kind of physiologic review, and now we'll talk about initial management of pregnant trauma patients, and then after we review kind of maternal considerations, we'll talk about fetal ones. So obviously for patients who are not in the hospital at the time of injury or of their critical care stay, we have to focus on safe transport of patients to the hospital, preferably to a trauma center that is equipped with a trauma service, which is, a general surgery-based group of obstetricians and gynecologists to manage these intricacies of pregnancy, as well as NICU for any fetal concerns. All patients of reproductive age should have a screening beta HCG. We are not infrequently called about patients who are involved in traumatic, whether it's falls or car accidents or other injuries, who just happen to be pregnant, and we find that out on screening beta. And so that's important to know, because as we talked about, some of those physiologic changes are pretty apparent even at 8 weeks. Multidisciplinary approach is really important for these cases. In terms of the obstetrician's role in that immediate kind of trauma survey, I think importantly is a quick assessment of gestational age. Determining whether or not we have a viable pregnancy or not is important. Assessing the fetus for heart rate. And then really, I think the main thing initially is to get a left lateral tilt to try to improve the patient's cardiovascular status while that initial trauma survey is being undertaken. And then from that point, it's really routine protocols in terms of adult trauma and ABCs and all of that. Initial management of airway, breathing, ventilation. Remember that aspiration is a pretty big concern for these patients because they have a relaxed lower esophageal sphincter, and consider an OG placement if they are intubated. We'd like their SATs to be maintained in the high 90s just to ensure fetal perfusion. Patients who are pregnant patients with respiratory distress can tire out pretty quickly because they have a decreased pulmonary reserve and they're working pretty hard over a gravid abdomen. And so, you know, patients that we've seen with flu, COVID, other pulmonary injuries can tire out and decompensate pretty quickly. So considering early intubation is important. Sometimes there's edema in the upper airway, and so anticipation of a difficult intubation is important. And if a chest tube is required, consider placing that a couple intercostal spaces above the normal landmarks because the gravid uterus does displace the diaphragm cephalad. In terms of circulatory support, again, that left lateral tilt is really going to improve preload and cardiac output. We recommend leaning towards heavy volume replacement early. That's been shown in our studies to reduce morbidity. Vasopressors obviously are necessary in circumstances, but they can reduce uterine blood flow. So an attempt to replace volume first is obviously a good first line management. IV access for both of our specialties is incredibly important, whether we can obtain that peripherally or require central access. And then hemorrhage management, we pretty liberally use TXA for patients at high risk of bleeding in an obstetric sense if we're, you know, planning a delivery that we anticipate a large blood loss. But TXA within 3 hours of injury may help mitigate some hemorrhagic morbidity. Again, a fibrinogen of 200 to 300 is necessary for adequate coagulation. If fibrinogen is below 100, those patients should be really strongly resuscitated for DIC. And then similar to other trauma recommendations, the massive transfusion protocol of 1 to 1 to 1 is generally recommended for this patient population as well. If CPR is required, remember that the uterus and placenta are a massive shunt and that a large percentage of cardiac output is going directly to the uterus. External chest compressions are really challenging in these patients because there's decreased, do I have a comment? Are really challenging because of reduced chest compliance, but also placing the patients in a left lateral tilt is going to maximally augment their cardiac output. But again, if the patient is at a tilt, it's going to make it really hard to deliver effective contractions with that vector being off center. And again, just remembering the left lateral tilt. In a patient who's pregnant, particularly a patient who is over 24 weeks pregnant, emptying the uterus by cesarean delivery will improve the effectiveness of compressions and will improve your ability to resuscitate the mother, even if that does not provide any fetal benefit. Recommendation for perimortem cesarean, it should be completed within 4 minutes of maternal cardiac arrest with the goal of delivering a fetus by 5. This largely has to do with the fact that the chest compressions are not terribly effective in this patient population, and we're probably only delivering 20 to 30% of the effectiveness of what their heart can pump. And so over those 4 to 5 minutes, the fetus is really compromised. Fetal survival is only 5% after 15 minutes. So if compressions are initiated, then our team should be present at bedside to hopefully do a resuscitative hysterotomy so that we can allow for your team to continue maternal resuscitation. The question in the chat is, what are your thoughts on quick clot to penetrating trauma in the gravid abdomen? I love that as a way to kind of get us to the operating room. We use quick clot in conjunction with you guys for various, coagulopathic patients that we take back for different things. I think that would be a great way to kind of mitigate ongoing blood loss while you get them to an operating room. In terms of continued assessment after the initial ABCs are evaluated, if patients are having seizures, obviously they might have a brain injury, but don't forget about eclampsia. The eclampsia labs are going to be tied into the routine labs that you would have for any trauma patient. We are basically looking at their CBC, and then we're looking at LFTs and creatinine and things like that. RH status is important. Most trauma patients who are RH negative are going to require ROGAM. You can consider for RH negative patients ordering a KB. I'll talk a little bit more about that in a later slide. Routine labs, if you see gross or microscopic hematuria, don't forget about pelvic fracture. And one thing that comes up for obstetric patients quite often is if you obtain a urine specimen that is not capped, we can see vaginal contamination of that urine specimen. So for patients who, for example, have ruptured membranes, there's a lot of protein in the amniotic fluid, and that can really contaminate your urine specimen. So most trauma patients are not are going to require a cath QA, but just keep that in mind if it's a clean catch. Imaging. Super important to order the test that you want, not a test that you are kind of ordering on the basis of the fetal benefit. Please consider the mother first and foremost. Bedside ultrasound during the initial trauma survey is incredibly valuable, both for obtaining a fetal heart rate. You can get a pretty quick assessment of gestational age, and fast scan looking for intra-abdominal fluid. Sometimes if there's a pretty traumatic injury, we can see uterine rupture and we're looking for fetal parts or different things outside of the uterus. In terms of imaging, I think, one thing that OBGYNs see a lot of is concern over imaging a fetus. There's a nice practice bulletin from ACOG, which is kind of our governing body, which says fetal concern can lead to the unnecessary avoidance of useful diagnostic tests or the unnecessary interruption of breastfeeding. If you're trying to do like the absolute safest thing for everybody, ultrasound and MRI are not associated with fetal risk, but and gadolinium is safe in pregnancy and breastfeeding. But the most important thing is to order the test that's going to give you an answer that you want. If you try to order a safer test like an ultrasound or an MRI, which is not going to answer the question, you're just going to delay their care, because then you're going to have to order the test that you actually want. So the other thing is these pregnancies, when they do deliver, they're going to be imaged up and down because of the trauma. They're going to need their own lines. So there's really no concern for routine use of X-ray, CT, other imaging modalities. So please order the test that you want. There's a nice little mnemonic for a focused history for pregnant patients called CODE. So once you get your patient stabilized and you're trying to gather some more information, find out if she has complications in pregnancy. Does she know about any gestational diabetes, chronic hypertension, anything regarding the placenta that's abnormal, like placenta previa, twins, a variety of complications. Getting an obstetric history, did they have prior cesarean, did they have prior vaginal deliveries is important, and who their doctor is, so you can try to get records. Asking patients how they're dated is also important, and what their estimated due date is, so that you can look at kind of what their due date is and how far along they're supposed to be compared to their exam. And then in terms of the event details, this is stuff like, are they losing fluid, vaginal bleeding, having contractions? Do they feel their baby moving? Do they have abdominal pain? The physical exam is going to be the trauma survey that you all are going to do. And then in terms of our obstetric specific exam, I'll get to that in the next slide. One of the other initial things is gathering a gestational age. One of the quick ways to get an accurate, fairly accurate gestational age on a non-obese patient is to check for fundal height. And so if you measure from the pubic bone to the fundus, the measurement in centimeters will roughly correlate with their gestational age in weeks. 20 weeks of pregnancy is about the level of the umbilicus, and viability now is anywhere around 23 weeks, but in terms of a trauma, that's going to be a real hard line. So if you're looking at 23 to 24, but certainly if their fundus is above the level of the umbilicus, I would consider them to be viable. If we have more time and the patient is stable, we can do an ultrasound biometry, which is basically the ultrasound allows us to do a series of measurements and then create a gestational age based upon those measurements. Another thing to look for is presentation. Are they head down? Are they feet down? Is there a heart rate? And is the placenta looking normal? The sensitivity of ultrasound to detect a placental abruption is not great. That said, if you see a huge retroplacental clot, the sensitivity is great, and we should move forward with treating them as if they have a significant trauma and a placental abruption. In terms of obstetric specific exam, the abdominal examination, we're looking for tenderness, rebound guarding, bruising that's in a certain distribution that can suggest kind of mode of injury. Things that we're thinking about here is placental abruption if patients are super tender. Labor, patients are going to have rhythmic, kind of firmness of their uterus, and that's usually palpable. Uterine rupture can present with pain. Some of our patients are not going to be responsive, so that wouldn't really be super helpful. Patients who have, again, uterine firmness, you're thinking about preterm labor. And then on your FAST scan, we're looking for palpable or visible fetal parts outside of the uterus, or a large amount of free fluid concerning for amniotic fluid in the abdominal cavity, or bleeding in the bleeding in the abdomen. On vaginal exam, we're looking for bleeding that can give us a clue about whether they are miscarrying, they have a placental abruption. If there's any significant trauma or lacerations to the external genitalia, the internal vagina, cervix, patients with placenta previa, which is a placenta that's overlying the cervix, they can have significant bleeding. Leakage of fluid, we can have traumatic rupture of membranes. Cervical exam, whether or not they're dilated, can tell us whether they're miscarrying or they're going into labor. And then again, lacerations, direct trauma to the lower pelvis or pelvic fracture. Obviously, patients who are unstable or we have concern for intra-abdominal injury, refractory hemorrhage, those are patients who are going to go to the operating room, usually with both of our teams present. Uterine injuries may require hysterectomy to control bleeding. There are times where the uterus is so significantly damaged that repair is impossible, and so a hysterectomy may be required to fix that. Fetal death does not necessarily require a C-section, so if we know that the fetus is demised, we don't necessarily have to deliver by cesarean section if we're going back for an XLAP to rule out other injuries, particularly for a patient who is stable enough that we can leave her pregnant. We could do the XLAP, repair whatever other injuries are present, and then monitor her pregnancy post-operatively. This seems like a crazy thing to say, so let me give an example. We had a patient probably about a year and a half ago who came in with a gunshot wound to her abdomen. The entry point was on more of her lateral side. The bullet kind of grazed the top of her gravid abdomen, and the exit point kind of came out her back on the other side. And her fetus was fine. I think they placed a couple stitches on the fundus of her uterus just to control that graze kind of mark. Her bowel was run, whatever repair was done, and then she continued that pregnancy to term, and then we delivered her. So just because we do an XLAP does not always require that we're going to do a delivery. If we're in the operating room with a pregnant patient, it's important to remind anesthesia to maintain maternal pressures that are going to support fetal perfusion, that we have a left tilt, and then generally we check the fetal heart rate both before and after surgery. Obviously, we are in agreement that patients who are having an XLAP need a generous vertical midline so that we can carefully evaluate all of their compartments. And then particularly for coagulopathic patients who can't be safely closed, or again, we're using a quick clot to control pelvic bleeding. Sometimes we work together to place an Apthera and then come back at another point and close them or reevaluate their pelvis at a later point in time. This is a really nice flow chart of basically all the things that I just talked about. Again, speaking to the patients who are going to be still pregnant after an initial trauma evaluation or who have non-life-threatening injuries, those patients who are viable are generally going to require either a stay on labor and delivery for fetal monitoring, or they're going to have remote monitoring on a different unit depending on which of their injuries is more significant. But I'll go into a little bit more detail, the monitoring for the fetus in a later slide. Okay, let's talk about that fetus. Again, 1 in 3 patients admitted after trauma will deliver during the hospitalization, and their management should be dictated by severity, and the initial focus should be on maternal stabilization. Both short and long-term morbidity of surviving fetuses is related to the direct and indirect consequences of maternal trauma. So if the mom is hypotensive, hypoxic, has an abruption, if the fetus is delivered prematurely, all of that is going to be made better by making mom better. And so I think sometimes there's some ethical dilemma of which patient we're focusing on more. And the answer is that we are always focusing on mom. We can better resuscitate a fetus who is in utero than we can outside most of the time. And so if we can make mom better, then we can make baby better. Monitoring is going to vary depending on the symptoms, their mechanism of injury, their gestational age. Obviously, if they're term, we're probably just going to deliver that baby. Preterm babies are going to be monitored anywhere from 4 to 24 hours. We know that the risk of abruption is greatest within the first 24 hours after delivery. We also know that prompt fetal evaluation and intervention by C-section, if we do have fetal distress, is imperative to improving fetal morbidity. And so this isn't where the partnership between OB and trauma is really important. This is a flow just kind of looking at what the fetal considerations should be. So again, the initial survey of the trauma, we're looking whether or not there is a heart rate present. If there is a heart rate present, then we're trying to determine whether or not that fetus is viable. If it's not viable, a simple spot check is fine, just verifying that it is alive. If it's viable, then we're generally going to recommend some form of continuous monitoring for 4 to 24 hours, depending. If patients have symptoms, whether those are contractions, bleeding, pain, bruising, obvious injury to the abdomen, if the fetus's heart rate tracing is abnormal or mom's vital signs are abnormal, or obviously if she's coagulopathic, that is going to change the amount of monitoring, and those patients are going to need extended monitoring for 24 hours. I think this is important to point out too, that there's no point in monitoring if we can't intervene. And so what I mean by that is, let's say that we have a maternal, pregnant patient comes into the ED and we want to get a CT scan emergently to rule out, her injuries. There's really no point in monitoring that baby continuously while she goes to the CT scanner, because we need to figure out if mom's okay before we can make a surgical plan. So if you're not going to use the data that you're gathering from the monitoring, then you probably shouldn't monitor at all. But this is where good partnership with MFM and your obstetrics team is going to be helpful. Again, this just talks about when you can discontinue monitoring after 4 hours, basically if they're doing great, or if patients are going to require 24 hours of monitoring. So, when I think about hemorrhage, I think about maternal hemorrhage. So there's a huge amount of blood flow going to the uterus during pregnancy. They sustain trauma and they have maternal intra-abdominal bleeding. The other bleeding that we worry about is feto-maternal hemorrhage, which means that there's actual fetal bleeding into maternal circulation. The fetus tiny fetus only has about 200 to 300 cc's of total blood volume. So even a small amount of bleeding can be pretty significant. We're worried about fetal anemia, fetal death, and then kind of longer term consequences are maternal alloimmunization if there's an Rh negative mom and there's an Rh positive fetus. One of the tests that we use to determine this is a Clive-Howard-Betke test, which measures the percent of RBCs in the maternal blood system, and that allows us to determine the RhoGAM dosing. For most patients who are Rh negative, who experience trauma, the standard 300 microgram dose should be sufficient. But for patients who sustain a bigger trauma, they may require more. And so that KB will help us determine the dose. We generally do this after like 12 weeks, but I'll tell you, if patients come in Rh negative and they're in the first trimester, the default is to just give the RhoGAM, and I think that's fine. Other medications that we think about for pregnant patients who experience trauma are betamethasone, which is recommended generally from the point of viability, which is about 23 weeks, to about 34, 36 weeks, depending on circumstances. And that improves fetal lung maturity if we're anticipating a preterm birth. That's given as a 12.5 milligram dose. It's given ×2, 24 hours apart. There's also rescue dosing if they stay pregnant for a certain amount of time and then they experience symptoms again in the future, but that's an MFM kind of guideline that we go by. And then don't forget tetanus boosters for penetrating trauma. Patients during pregnancy will routinely get a Tdap every single pregnancy at about 28 weeks, so they may have already had it, but you're not going to be faulted for repeating that dose if they've trauma.
Just jump around on that trashy place.
Okay, so I'm going to go over just some like types of injuries and then pearls of practice, and then open it up for questions. So one thing I wanted to comment on is something that OBGYNs refer to as obstetric reserve. Generally, our patients are young and they're healthy at baseline, and they can tolerate a good amount of blood loss before they have symptoms. Keep in mind also that because of their increased heart rate at baseline, their increased plasma volume at baseline, you may have a patient who looks really, really good until there's a critical amount of blood loss present. And so for healthy pregnant patients, they may not show symptoms of hemorrhage until they've lost about 15 to 20% of their total blood volume, which is about 1,200 cc's. If you look at this chart on the left, it kind of goes over what symptoms you might be expected to see for patients who are pregnant, who are having blood loss. So again, mild blood loss, even 1,200 to 1,500 cc's, they're not really going to look much different than they do at baseline. Most of our pregnant patients have a heart rate of 95 to 105, so that's not helpful. Their blood pressure being 70 to 75 is probably not going to alert anybody. So just keep that in mind. It's not until you get to moderate or severe blood loss that you start seeing symptoms. Another thing that's really important for us is that because of this obstetric reserve, our patients generally look really good until they look really bad, and there's no gray area in between. And so we see this not infrequently with ruptured ectopics who are sitting in the ED. It's like, oh, she looks totally great. Let's get her to the OR in kind of a reasonable fashion. And then all of a sudden, the patient becomes altered. She's confused, and then her blood pressure is plummeting, her heart rate is up, and everyone's like, oh my God, she just went off the cliff. And so that's pretty standard for pregnant patients, and that's something really, I think, for any emergency providers to keep in mind, is that they look really good until they don't. Blunt trauma, if you have blunt trauma, particularly to the abdomen, think placental abruption. About 40% of patients with severe blunt trauma will have a placental abruption. Even about 3% of minor trauma victims are going to have that. And, you know, that comes down to some physics, which I'm a total dork and I love physics, but the shearing forces involved in the uterus are pretty interesting. You've got the muscular uterine wall, which is pretty elastic, and then an inelastic placenta. The amniotic fluid is also non-compressible. So when you put something that's pretty mobile and elastic next to something that's not, now at that placental uterine interface, you have the potential for shearing forces. Similar to head injuries, you can have coup and counter-coup reactions. So you can get kind of shearing forces that cause a contralateral injury, even if it's not the area where they were directly injured. I think about this too with patients who have a really substantial fall and they fall on their butt. They may have a placental abruption just from the force of their fall because of these shearing forces. Again, patients who have an abruption are generally going to have it within the first 24 hours after trauma. And patients with an abruption, it can be concealed and they might not have any vaginal bleeding. So just because patients don't have vaginal bleeding does not mean that they do not have an abruption. For patients in the first trimester, remember that for patients less than 12 weeks, the bony pelvis is generally protective, but maternal trauma, which causes other hemorrhage, will result in hypotension, and that uterine hypoperfusion can cause miscarriage. So even if there's not direct trauma, maternal hypotension is enough to cause significant issues with the fetus. Specific to motor vehicle collisions, crash severity and improper use of restraint is the main issue. Obviously, ejection and head trauma are both poor outcomes for both fetus and mom. Blunt trauma, uterine rupture as a result of blunt trauma is not as common. This is less than 1% of all pregnant trauma victims, but it's pretty profound. Remember, there's a huge vascular supply going to the uterus, and this can rapidly cause hemorrhage or coagulopathy. Also, keep in mind that a uterus is like a shield in the torso, and so the fetus is going to sustain injury first, and the uterus is going to sustain injury first rather than some of the visceral organs. So that might be a good thing for mom that her visceral organs are protected, but it often means that whatever the mechanism of injury was, the kind of fate of that fetus is kind of predetermined by that injury. When I was a resident, we had a trauma, which was a car crash, a pregnant patient who had twins, and she was T-boned. And so one of her twins was sitting more on the left lateral aspect of her body, and the other twin was on the right. And the twin that kind of sustained the injury on the left when she got T-boned was pretty severely injured, multiple fractures throughout its body. Was demised by the time she arrived at the ED. The other twin was alive and did fine. And I think that that twin sustained all of that injury, and because of the kind of mechanics of the uterus and the amniotic fluid and all of that, it kind of buffered the patient and the other twin from really catastrophic injury. And so we pretty quickly delivered her by C-section and were able to salvage that second twin. Many times these uterine ruptures are going to require exploratory surgery. Those patients are generally going to be pretty unstable if they've gotten their injury is involving any of their vascular system to the uterus. If there is bony fetal parts outside of the uterus, it's really important. I mean, obviously, we're going to be running the bowel anyway with you guys, but looking for lacerations specific to the fetal parts injuring the maternal bowel is important. And those patients, again, might require emergency hysterectomy if repair is impossible or the hemorrhage is severe. Penetrating trauma. This is less common, 9% of all pregnant trauma admissions, more commonly gunshot wounds and stabbings. These tend to be more favorable in terms of maternal morbidity compared with blunt trauma because the uterus might absorb the projectile and the viscera is protected. Again, these patients are going to require an XLAB most of the time to evaluate their injuries. They're going to need tetanus prophylaxis, and then we would largely defer to you all for management of bowel injury, debridement of whatever is injured, antibiotics, etc. The fetus obviously has a more poor prognosis with these type of injuries, and about 71% of fetuses with a maternal gunshot wound are going to demise, and about 42% with stabbings. Slips and falls, just reminding this normal physiology of pregnancy. There's more joint laxity. There's an altered center of gravity. Also, with a big gravid uterus, sometimes even thin patients can't see their feet. And I don't know how many of you guys on the call have young children, but this picture is my life, falling over toys that my kids leave on the stairs. About a quarter of all women will fall during pregnancy, most of which are going to be indoor accidents, and about 40% of them are going to involve stairs. These patients have a 4 times increased risk of preterm labor, 8 times increased risk of abruption, and a 2 times increased risk of fetal distress. So still a pretty big deal, even if they just fall on their butt. Burns, these are far less common, and kind of the literature is limited to case reports and case series, but in general, if the total body surface area affected exceeds 40%, mortality rate is nearly 100% for both. Those patients with severe burn, if they present to the hospital with a live fetus, then they should probably just be emergently delivered by cesarean to try to salvage the fetus as soon as possible. Domestic violence or intimate partner violence. This is another area where I hinted at, disparities of healthcare and the association with substance use disorders, poverty, inadequate resources, etc. There's a lot of comorbidity with depression and anxiety. One particular study noted that 1 in 12 pregnancies in the American inner city are affected by intimate partner violence. About 20% of all non-fatal violent crime is from a woman's intimate partner. And homicide rates for Black women are 3 times higher than that of white women in North Carolina from a study a few years ago, most of which are going to be gunshot wounds, stabbings, and followed by strangulation, which are just, again, speaking to the healthcare disparities that we see in our reproductive age women. Suicide, this is not terribly common. It's 0.4 of, in 1,000 pregnancies. Suicide accounts for 20% of all postpartum maternal deaths from all causes. And the best predictor of risk is substance abuse. There's a lot of overlap between patients with substance use disorders and obviously postpartum depression. Prevention, involved in routine prenatal care is depression screening, intimate partner violence screening, which we do for all patients on their initial evaluation for pregnancy as well as postpartum. And then in terms of trauma prevention, correct seatbelt use is the green lady to the right. So the shoulder harness over the collarbone between the breast and then the lap belt as low as possible across the hips, but not the abdomen. And again, ACOG recommends this to mitigate maternal and fetal injury during pregnancy. I just wanted to make a final comment about the importance of collaboration. It's one of my favorite parts about my job is my multidisciplinary clinic and getting to work with all of our service lines so that we can bring all of our expertise to taking care of a patient. And I feel like we all do a really better job when we all work together. And so thanks for letting me spend lunch with you. I really appreciated getting to chat with you guys today.
Thanks, Dr. Woolworth, for joining us. That was really informative. I guess I'm going to try to moderate the chat here. We've got a few questions coming in. So Scott asked a question and says, so as total blood volume increases in the pregnant patient, the goals or endpoints change on traditional fluid resuscitation, whatever those might be. Any consideration to be aware of with the increased use of whole blood in resuscitation?
I don't know if I'm necessarily like as up to date on all of that as you guys, but I will say that we use a lot of cell saver in my Accreta cases for planned surgical cases with pregnant patients, and I find that is kind of nice because we're giving it back as one instead of all the products. But You know, in general, for patients with bleeding from an obstetric standpoint, I usually like to start starting with 2 units. 2 units is fine. If I give them 4, then I'm generally considering some FFP and checking coags, and then moving from there, adding cryo if their fibrinogen is low. But I don't, you know, I think that we are always trying to, for young healthy patients, we're usually giving them a good amount of fluid during their resuscitation and trying to, you know, give them enough fluid that we can try to mitigate the need for vasopressors. But obviously, if they're needed, they're needed. I would say, just in terms of like where we want them to end up, I usually want my patients to end up around a hemoglobin of 10 so that they can heal and they can lactate if they want to. And I'm not sure I'm answering the question entirely, but
we got a few more up in the chat. So Dr. Suchdev, I think I saw your hand next.
Yes, thank you. Wonderful talk, Dr. Woolworth. It's been great collaborating with you. I had a question for you about placenta abruption. You mentioned that many times it can occur without any vaginal bleeding, and it can occur, you know, in any trimester. Correct me if I'm wrong, but my question for you was, once you're admitted to your service, how do you screen for that with ultrasound? And if you do find an abruption, what's the management? If they're a viable gestation, then do you always deliver them, or can you manage them based on different grades of abruption? And kind of how does that kind of algorithm work for those patients with abruption? Thanks.
Yeah, that's a great question. I mean, on one end of the spectrum, we have like catastrophic abruption with a patient who comes in who's hemodynamically unstable, whose, you know, vital signs are not normal. And those are pretty easy patients because they rapidly go to the operating room. In general, if they're that sick, they're going to have a fetal heart rate tracing that is going to suggest some fetal distress, whether or not that's decelerations. If we have a fetus that's significantly anemic because of bleeding, we can even see a sinusoidal pattern on their heart rate tracing. So we're using all of those kind of pieces of maternal vital signs, the fetal vital sign, which is their heart rate tracing, and then in combination with the patient's labs, their vital signs, et cetera. The ultrasound is kind of adjunct because the sensitivity is not great. If there's a huge abruption, we can generally see it on ultrasound, but smaller abruptions, the sensitivity is not great. And so for those patients who are more in the middle area, we are monitoring them with serial blood work. So we're doing coags and CBCs at some interval of time. We're monitoring their heart rate. We're monitoring fetal heart rate, you know, all the maternal vital signs, and then just kind of looking at them over time. Sometimes we have patients who have an abruption that stabilizes, and so and that's really dependent, like gestational age. If their gestational age is not favoring a good outcome for delivery, let's say they're 24, 25 weeks, and we can keep them pregnant and we think the perfusion of the placenta is still adequate, then we might keep them pregnant and, you know, try to get betamethasone on board to better improve fetal lung maturity and just get them set up for delivery. So they don't always have to be delivered. And if there's fetal and maternal stability after some point of time, we can keep them pregnant. You know, and sometimes they turn, like they look pretty stable in the beginning, and then after 6 hours or so, they're not. It kind of varies, but an abruption in the early trimester is something like you would see on ultrasound reports. They'll talk about like a subchorionic hemorrhage. It's basically a fancy way of saying an abruption in the first trimester. So there's some amount of blood or bleeding that is retroplacental or behind the placenta, between the, you know, the interface of the placenta and the uterus.
That really helps. Just a little follow-up question. If you have a 30-week fetus and you've got placental abruption, it's not catastrophic, but they've kind of stabilized, all your monitoring is okay, they're potentially viable, they're potentially deliverable, and go to the PICU. How long do you keep observing them in the in your ward? Like, is it a mandatory protocol that you have for these abruptions, or is again it's going to be kind of a clinical judgment that you use?
I think it's clinical judgment depending on all of the factors. It's depending on maternal stability, it's fetal stability, it's how remote from term they are. You know, we're balancing the fetal morbidity of a preterm delivery. You know, I wouldn't say there's criteria, but I will say that if a patient is requiring transfusion to stay pregnant, that's generally my eject point where I'm like, all right, we've got to deliver this patient. So I think it really depends. If you have a big abruption, a lot of times the patient's spontaneously going to go into labor anyway, and so the decision's going to be made for you. But sometimes keeping them pregnant is just a way to, let's say they do need stabilization with some blood product, or we do want to try to get betamethasone on board. Sometimes we're just trying to get them a couple days. Other times, if the bleed is not significant, we might try to get them longer. But it is all dependent on a lot of variables, and there's not really any hard, fast recommendations.
Thank you so
I
much.
was
Great
just-
answers.
Can I add one comment? Well, this is
Please.
Becky Pollock. I'm with maternal fetal medicine. And I
Please.
think, so as Melissa mentioned, somewhere in like the first trimester, this term of subchorionic hemorrhage, which can be spontaneous or could be related to trauma, in the second trimester then becomes a chronic abruption, which can at any moment turn into an acute abruption. And I think one of the challenges we're facing now is, especially as we approach that quote unquote point of viability, sometimes we do have to have a really serious discussion about like how much ongoing maternal resuscitation with transfusion is safe in order to try and achieve a higher gestational age versus when does that risk of coagulopathy and risk of transfusion really become life-threatening to mom. And so I think these are really hard decisions, knowing that in the setting of that consumptive coagulopathy, these women with an abruption, whether it's concealed or not, can become very sick.
Thanks, Becky.
Dr. Thomas?
Hey,
A great talk. I was pretty surprised to see with the burns that 40% was the mortality point. You know, 20 to 40-year-old women, we would otherwise not pregnant expect about a 20 to 30% mortality. Any thoughts on what the high mortality rate is with the pregnant patient for that level of burn? Thanks.
I don't. I didn't read that extensively on it. I'll be completely honest. It came out of an article that was an obstetric article, so I'd be happy to go back and look at it. You're saying that
No worries. I'm assuming it's probably the fluid shifts and the differences that occur during pregnancy. But I was just curious if you'd seen anything about that, because that's certainly higher than we would expect in a non-pregnant patient.
where's your line again?
So for 40% more total body surface area in a otherwise 20 to 40-year-old adult patient, we wouldn't expect a mortality of higher than 50% for sure.
Okay.
I assume it's something different with the pathophysiology of being pregnant. I was just curious because I was kind of surprised to see that.
Yeah, the article, one of the main articles that I used is by Haywood Brown, which was published in 2009, if I can date myself here, but that is coming out of obstetric literature. So I think that they extrapolated this data. I think you're probably more accurate because it's more up to date with our, more current burn protocols and things, but certainly, I think if we've got a high surface area of burn, we should definitely consider delivery of the fetus because they're not going to benefit from being in utero.
Dr. Jacobs, you have a hand up?
Yeah, I do. This was a great talk. I have a very, very straightforward, practical question.
Mm-hmm.
where should the perimortem C-section be done? And so this stems from a case I had a couple of years ago. Patient came in, I can't remember, 34, 35 weeks. And mother was fine. Baby was in trouble, big trouble, D cells into the 30s and 40s. And so we've got a couple of different options in terms of operating rooms, or we could do a C-section in the emergency department. So we can do it in the emergency department, we can do it in our trauma room, or we can do it upstairs in your OB room. Given the time constraints that you listed in your talk, I was roundly criticized for where this got done. And so I'd just like to know what your thoughts are.
Yeah, I think that this is a really interesting topic because this always comes back to our teams when we have a C-section in the ED. So I'm glad you brought that up. I think it really comes down to maternal stability. And if you have a patient who is not anticipated to make a recovery, so if I'm initiating CPR on a pregnant patient, I have already accepted that I'm likely not going to get her back because of the constraints of CPR on the gravid patient. And so in that setting, if you're doing CPR in the ED, the C-section happens in the ED. In terms of your patient, where the patient is relatively stable from a maternal standpoint, but we have a fetus in distress, my preference would be to put that patient in an operating room because it's going to have better chances of sterility, better chances of equipment. I think all things said and done, the morbidity, the maternal morbidity associated with that delivery being done in an ED are really high. And so I would much rather her get to an operating room. I mean, my understanding and the experiences that I've had is we can get a patient from the ED to the trauma OR upstairs pretty quickly. And so I would rather stat section her in an operating room if I think that if the maternal patient is going to survive, I would rather it be cleaner.
Dr. Jacobs, you'll feel better. Dr. Pollack says in the chat, not a straightforward question at all. She does say call NICU and doing the ER, but obviously this is situation specific.
Yeah, and I would just say if that's the expectation, then we probably need to do a little bit better job. I don't know if your team is knows where the trauma operating room is, but I think your 4-minute or your 5-minute rule, rolling out of our trauma room, we may get to our operating room in 4 minutes, maybe. But I can tell you that baby's not going to be delivered in 5, and so we probably need to do some. Some legwork in trying to make sure that our system can accommodate that. Thanks.
I have 2 comments on that. One is if you're doing maternal CPR, then it should happen in the ED. But if the patient is not getting CPR, she's stable enough, I think we can get a baby to an operating room to do a delivery within a few minutes. That said, I'm also the director of OBGYN simulation, and preparing for this talk made me think that this would be a great opportunity for a joint simulation event where we could talk about some of these maternal traumas and kind of work through the logistics. We had an eclampsia care event a few years ago, which really prompted a look at where we stored our magnesium, how the nurses could access it. And we did an in situ simulation, which was really valuable because it allowed us to test out the system limitations. And so that might be something that we could look into is like how feasible is it to get a patient from an ED room to an operating room for that delivery. And I think that might be a good project to look at for our teams. But I agree with Dr. Pollack. It's definitely not straightforward. And this also happens with our critical care patients who are pregnant. Like we never want to do a crash section at the bedside, but we can. And I think if we have a few minutes to spare, and the mom is stable enough and we think she's going to survive, I think we should probably get her to a cleaner operating room. But of course, if she's getting CPR, I would do it in the ED.
Great questions and comments. I was thinking the same things, Dr. Woolworth, about a combined simulation. Every time we do a combined trauma simulation with the ED or another group, we realize that there's either something that we need that's not there, or nobody knows where it is or how it's packaged and so forth. So I think we on the trauma side would absolutely support that. Any other questions or comments? I don't see any hands raised, but if anybody has anything, please speak up.
I'd love to make a quick comment. I think there's a lot of room for these patients to be, you know, a lot of room for collaboration. And we recently had a patient that that was having a gynecologic hemorrhage that we had some delays getting her back to the OR. And so we are working right now on creating a GYN hemorrhage, kind of like a code stroke or code any of the other codes that we have in place for EPIC. And so I think that's another place that I would love input from your teams as to kind of how to initiate that care and how to get those patients more swiftly from the ED into an operating room if they're experiencing hemorrhage.
Great. Other comments from the group? Well, I'd like to thank Dr. Woolworth again for joining us. It's obviously very informative. We all learned a lot, no matter what our perspective is. So thank you for the comments from the group, and thanks for being here with us today. And if there's nothing else, we will adjourn, and we'll remind everybody again about the MTAC Trauma Conference. Scott did put the information in the chat again.
Thank you so much for having me. I really appreciated the opportunity. And again, always open for collaborative projects. So let me know if there's anything I can do to help.
Great. Be careful what you ask for.
I know, right?
All right. Thanks, everybody. Have a great day.
Take care.